Imagine a disease that can wear 1,000 faces and change its identity while doctors are trying to catch it. That disease is cancer. For decades, humanity has asked the same urgent question. Why can we land machines on distant planets, decode the human genome, and replace failing hearts, yet still cannot cure cancer once and for all? The answer is anything but simple. The first mistake is hidden inside the word cancer. We speak about cancer as if it were one enemy. It is a vast family of diseases that begin in different tissues, follow different genetic paths, and respond differently to treatment. Two tumors in the same organ may also be biologically different. Even two patients with the same diagnosis can carry cancers driven by different mutations. That means the cure for one person may do almost nothing for another. Cancer is not a locked door waiting for one perfect key. It is a corridor filled with doors, traps, hidden passages, and locks that keep changing shape. To understand why, we must begin inside the human body. Most cells follow strict rules. They grow when needed, repair damage when possible, and die when their time is over. Cancer begins when a cell starts breaking those rules. It may ignore signals telling it to stop dividing. It may recruit blood vessels to feed itself. It may hide from the immune system. It may eventually travel to distant organs. None of this usually happens because of a single mutation. Cancer often develops through a series of genetic and cellular changes accumulated over time. Another mutation may allow the cell to survive in places where it does not belong. By the time a tumor is visible, it may contain millions or billions of cells. Those cells are not always identical. They may form rival populations inside the same tumor. Some grow quickly. Some survive with very little oxygen. Some are vulnerable to a drug. Others may already carry the ability to resist it. This hidden diversity is one of cancer's greatest weapons. A treatment can destroy 99% of a tumor and still fail. The surviving 1% may be exactly the group best equipped to return. It can also be harder to treat. This is why a scan that looks clear does not always mean every cancer cell is gone. A small number of cells may remain below the limit of detection. They can wait silently for months or years. Then one cell begins dividing again. To the patient, it can feel as if the disease came back from nowhere. Biologically, it may have never fully left. The emotional cruelty of cancer lies partly in that uncertainty. A person can finish treatment, ring the hospital bell, and still wonder what is happening inside their body. Every headache can feel suspicious. Every ache can sound like an alarm. Every follow-up scan can divide life into before and after. The science is complicated, but the human fear is painfully simple. People want to know whether the cancer is gone. Doctors want to answer honestly. Yet cancer does not always offer certainty. The challenge becomes even greater when the disease spreads. A tumor that remains in one location can sometimes be removed with surgery. But metastatic cancer has crossed a biological border. Its cells have entered blood vessels or lymphatic channels. Each step is difficult, yet cancer only needs a few successful cells. Once metastasis occurs, local treatment may no longer be enough. Removing one tumor does not remove invisible cells elsewhere. Systemic treatments must travel throughout the body. Cancer cells come from our own cells. A bacterial infection is caused by an invader that is clearly different from us. Many antibiotics can exploit features bacteria possess and human cells do not. Cancer offers fewer clean boundaries. Its cells use many of the same basic systems as healthy cells. A drug powerful enough to kill rapidly dividing cancer cells may also damage rapidly dividing healthy cells. That is why chemotherapy can affect hair follicles, bone marrow, and the digestive tract. The treatment is trying to attack the disease without destroying the person carrying it. That balance can also change from patient to patient. Cancer treatment is therefore not only about finding something that kills cancer cells. It is about finding something that kills enough cancer cells at a dose the human body can survive. Then scientists began discovering that some cancers depend heavily on particular molecular signals. Instead of attacking all dividing cells, targeted therapies aim at specific weaknesses. A tumor driven by one abnormal protein may collapse when that protein is blocked. For some patients, the result can be astonishing. But targeted therapy also reveals the power of evolution without implying that cancer can think. They simply vary. Treatment creates pressure. Resistant cells survive. Soon the tumor is dominated by cells the drug cannot control. Another pathway may take over the same job. It may change how it repairs damage. It may transform into a different cellular state. The medicine that once worked beautifully can slowly lose its power. This is natural selection unfolding inside one body. Sometimes it happens even faster. Researchers respond by combining treatments. One drug blocks the main pathway. Another closes an escape route. A third activates the immune system. The goal is to make resistance harder. Yet combinations can increase side effects. They can also create new selection pressures. The puzzle becomes more complicated with every move. Immunotherapy introduced another powerful strategy. Instead of directly poisoning cancer cells, some immunotherapies help the immune system recognize and attack them. In certain cancers, patients with advanced disease have experienced long-lasting responses. Some remain cancer-free years after treatment. These outcomes once seemed almost impossible. But immunotherapy does not work for everyone. Some tumors are highly visible to immune cells. Others are biologically quiet. Some surround themselves with suppressive signals. Some exclude immune cells from entering. Some patients have immune systems that cannot safely be pushed harder. Activating immunity can also cause the body to attack healthy organs. The same force that destroys a tumor can inflame the lungs, liver, intestines, skin, or glands. Again, the challenge is not simply power, it is precision. Precision is difficult because tumors live inside complex neighborhoods. Cancer cells interact with blood vessels, immune cells, connective tissue, nerves, and chemical signals. This surrounding environment can protect the tumor. It can limit drug delivery. It can help damaged cells recover. It can even convert nearby cells into supporters. A tumor is therefore more than a pile of malignant cells. It is an ecosystem. Destroying one species in that ecosystem may not collapse the whole system. The remaining parts can reorganize. Some cancers also contain cells with stem-like properties. These cells may divide slowly. They may survive treatments designed to attack fast-growing cells. Later, they may rebuild the tumor. Researchers are still debating exactly how these populations behave across different cancers, but the practical warning is clear. The most visible cells may not be the most dangerous cells. The largest part of a tumor may be easier to kill than the small population capable of restarting it. Detection adds another layer of difficulty. Cancer is often easiest to cure when found early, but early tumors may cause no symptoms. Screening can help, but no screening test is perfect. It can also find an abnormality that would never have harmed the patient. That creates the problem of overdiagnosis. Treating every detected abnormality can expose people to surgery, radiation, drugs, anxiety, and cost without guaranteed benefit. Patients and doctors must make decisions under uncertainty. The ideal test would find every life-threatening cancer early and ignore every harmless one. No current test can do that across all cancers. Liquid biopsies may one day detect fragments of tumor DNA in blood. They are already useful in some clinical settings, but using them to screen entire populations raises difficult questions. Finding something sooner is not automatically the same as improving survival. That difference must be proven in careful trials. Clinical trials themselves take time. A treatment can look promising in a laboratory dish. It may even shrink tumors in a small group of patients. But researchers must learn whether it truly extends life, improves quality of life, and remains safe. Cancer does not give science permission to skip these steps. But unproven treatment can waste time, money, and hope. The history of medicine is filled with ideas that seemed brilliant until they were tested properly. Progress requires both imagination and discipline. Money influences the speed of that progress. Cancer research receives enormous investment, but the problem is enormous too. Developing a drug can take years of experiments, manufacturing, trials, review, and follow-up. Many candidates fail because the benefit is too small. A successful drug must help enough patients to justify its risks. After approval, access becomes another battle. A treatment can exist and still remain out of reach. Countries may not be able to afford new medicines. Some therapies require cells to be collected, engineered, and returned. The scientific cure means little to a patient who cannot receive it. This is why cancer survival differs across regions, incomes, and communities. Biology matters, and so do health systems. Prevention is often less dramatic than a miracle cure, yet it can save extraordinary numbers of lives. Avoiding tobacco reduces the risk of many cancers. Vaccination can prevent infections linked to cervical and liver cancer. Protecting skin from ultraviolet radiation lowers risk. Reducing exposure to certain workplace carcinogens matters. Healthy weight, physical activity, and lower alcohol consumption can reduce risk for some cancers. None of these choices guarantees safety. People who live carefully can still develop cancer. People should never be blamed for becoming ill. Genes, age, infections, random errors, environment, and unequal exposure all play roles. Prevention is not a moral judgment. It is a population strategy. Early detection is also not a universal shield. Some cancers spread before they are large enough to find. A single screening schedule cannot fit every person. Family history can change risk. Inherited mutations can change risk. Age can change risk. Previous treatment can change risk. This is why personalized risk assessment matters. Personalization is also reshaping treatment. Doctors increasingly classify tumors by molecular features, not only by the organ where they began. This new map adds genes, proteins, immune patterns, and evolutionary behavior. It makes the complexity more visible. Artificial intelligence may help interpret scans, pathology images, and molecular data. But an algorithm is not a cure. It depends on the quality and diversity of its data. Technology must be tested as carefully as any drug. Another frontier is monitoring cancer over time. But cancer is a moving target. Repeated blood tests or biopsies may reveal new mutations, allowing treatment to change before a resistant population takes over. This adaptive approach treats cancer more like an evolving ecosystem than a fixed object. Some researchers are even testing strategies that do not aim to kill every cancer cell. Instead, they try to maintain a controlled population of treatment-sensitive cells. The goal is to delay domination by the resistant group. The reason is that maximum force is not always maximum control. In some settings, continuous aggressive treatment may remove sensitive cells and free resistant cells to expand. Adaptive therapy tries to manage that competition, but it represents a deeper shift in thinking. The future may not be one universal cure. It may be thousands of precise strategies. This can sound disappointing to anyone waiting for a single historic announcement. There may never be one morning when the world declares that cancer has been defeated. Instead, victory may arrive quietly through one vaccine, one early diagnosis, or one lasting remission. These are not small victories. Together, they change the meaning of a cancer diagnosis. The phrase "no cure" can also be misleading. Many cancers can already be cured, especially when detected early. Other cancers remain extremely difficult. The public conversation often combines these realities into one frightening image. It also hides inequality. A person diagnosed today may face a very different future than someone diagnosed 20 years ago. But that future depends on cancer type, stage, biology, health, location, and access. What exists is a rapidly expanding library of partial answers. Scientists are learning how tumors begin. They are learning which patients benefit from which treatments. When a drug stops working, the resistant tumor reveals a new weakness. When a trial fails, it can expose a false assumption. When one patient responds unexpectedly, researchers can investigate why. Progress often looks slow because the final answer is visible only after thousands of smaller corrections. Cancer exploits the same adaptability that makes life resilient. That is why the problem is so difficult. It is also why the fight is not hopeless. Human knowledge evolves too. Trials can become smarter. Prevention can expand. Access can improve. Patients can contribute tissue, experience, and time to research that helps the next person. Doctors can combine evidence with individual values. Families can demand clearer information. Governments can fund prevention and equitable care. The cure for cancer may not be a single weapon. It may be a system that detects earlier, understands deeper, adapts faster, and reaches everyone. That system is still incomplete, but it is being built. Every discovery closes one escape route. Every successful treatment redraws the battlefield. Every survivor carries evidence that progress is real. And every life lost reminds us that progress is not fast enough. So why can we not cure cancer yet? Because cancer is not one disease, not one target, and not one moment in time. It is evolution occurring inside the body. It is diversity hidden inside a tumor. It is biology intertwined with society, money, access, and uncertainty. But the word "yet" matters. It does not promise a miracle. It marks a direction. The future will likely defeat cancer piece by piece. Not with one perfect cure, but with many precise victories. And for the person waiting in a hospital room, one precise victory can mean everything.